on the image, I have the pleasure of sitting down with Dr. Joseph Lasky, Medical Director for Cure for the Kids, and Dr. Mark Nunes, Chief Geneticist for Cure for the Kids. Thank you for joining me today, you guys.
You're welcome. Thank you.
Awesome. Let's start by giving our audience just a little introduction into your specialty and what brought you to Cure for the Kids.
So I'm a medical geneticist, and so we deal with families who have rare heritable diagnoses. So for families with known diagnoses in the families, we're the expert in how to manage them and make sure all the I's are dotted and T's are crossed in their care. We see a fair number of families where we think there's a genetic issue going on and we don't know the name of that diagnosis. And so we've had a remarkable revolution in our ability to make those diagnoses. We used to make them clinically about half the time. And now with DNA testing, it's brought it to a new levels. And then we're entering into this really fantastic decade. One of the reasons that I'm at Cure for the Kids is this fantastic decade of being able to treat some of these diagnoses. And so for a long time, we didn't have therapies or treatment for rare genetic disorders. And now there are many, many avenues to treating, not curing necessarily, but treating rare genetic diagnoses. And so it's a fun place to be right now at this juncture.
Awesome. Dr. Lasky?
I'm a trained pediatric hematologist, oncologist, but as medical director at Cure for the Kids now, I also somewhat oversee all of the medical programs that are there now, which is many. So genetics is really our newest that just started earlier this year, and then of course we have pediatric oncology or cancer, and then hematology or blood disorders. We also have rheumatology. We have orthopedic surgery, we have physical therapy, we have a behavioral health department, so it's quite a large multidisciplinary pediatric and young adult and sometimes even older clinic that serves all of these patients in Southern Nevada.
So Dr. Nunes, you said you're new to the Las Vegas area. What was it about Cure for the Kids that made you say, I need to move to Las Vegas and be a part of this practice?
A number of things. I think the mission of the organization, truly is appealing, and everybody believes in that mission, and everybody's moving in the direction of that mission. And to be part of that, to be able to build something new, to be able to build a genetics program, and then particularly to be at an organization that has cure in its name. So treating genetic diagnoses, being a place that already for almost a decade has been treating genetic diagnoses, has already done gene therapy, for example. To be part of that kind of organization was very, very appealing.
And how about you, Dr. Lasky? What brought you to Cure for the Kids?
Yeah, so I've now been in Las Vegas at Cure for the Kids for 8 years. I was in Los Angeles for 14 years before that, and I think similarly to Dr. Nunes, it was really about the mission of the organization and kind of the need to fill a lot of gaps in healthcare that existed in Southern Nevada at the time. And I just wanted to be part of something that was really growing and doing what I think is really awesome things for the community of Nevada.
So tell our audience, what are some of the types of cases that you guys see in your patients?
A lot. So as I said, our subspecialties range from children with cancer and young adults with cancer, both children and adults with bleeding disorders, sickle cell disease, and then we can get, obviously, I'll let Dr. Nunes touch on the genetic diseases, which also overlap, of course, with every single specialty. But with rheumatology, we deal with things like lupus and arthritis. As a side effect of a lot of our therapies, whether it's rheumatology or oncology or genetics, children can have difficulties learning and difficulties with brain development and language development. And so our behavioral health department, really focuses on helping the kids get through those challenges and hurdles. So, it's those, patients that we see, and obviously, I won't go into too many details, but our most common cancer diagnosis in children, of course, is leukemia. In the bleeding disorder, realm, we deal with patients with hemophilia, which is the most severe bleeding disorders, and then also von Willebrand disease, and then we have a very large population of patients with sickle cell disease here in Southern Nevada too.
So there's something that you touched on, and we notice that a lot here at Steinberg as we see your guys' referrals come through, is not all of your patients are what you would consider kids for the name Cure for the Kids. So tell us a little bit more about those patients and kind of help the audience understand at what age are you too old to be a Cure for the Kids patient?
In a sense, as our mission really is to fill the gaps in healthcare, there's some, rare diseases that occur in children, including childhood cancer, that their health effects extend well into adulthood, and sometimes it's just difficult to find a good transition of care to an adult care provider here in the community, and we kind of just take up the reins and continue following those children and young adults. There are definitely pediatric cancers that then overlap into the young adult realm, and so we sometimes will co-manage those with our adult colleagues, and they ask for our help because we know the protocols and the treatments kind of better than they do even. And then with regards to the bleeding disorders, because those are disorders that started well into childhood, sometimes we're just so familiar with the management of those diseases that it's the pediatric hematologists who are best able to manage those, and that includes sickle cell as well, at least into young adulthood.
All right, Dr. Nunes, tell us all about genetics.
With respect to age limitations, Cure for the Kids likes to bill me as the first family geneticist in Las Vegas, and we've had some fantastic geneticists in Las Vegas. I tend to see trios, and so I say the child, the mother, and the father, and we identify genetic issues for the family. And so the two big issues are, can we identify something that needs medical management based on that genetic diagnosis? And so once you have the diagnosis, there may be some implications for healthcare for that child. The second is reproductive management for the family. And so families want to know, what's the chance that I'll have another child with autism? What's the chance that I'll have another child with cleft lip and palate? What's the chance that I'll have another child with osteogenesis imperfecta? And so that's a very important aspect of what we do. Perhaps the third one, I call diagnostic odyssey, which is, the families are looking for an answer. They've been dealing with this condition. They don't know whether it's genetic or not. They've been seeking an answer for a long time. And as I discussed, we have completed this decade where our ability to find that genetic answer, is so much greater than it was before.
How do you stay ahead of the curve with all of the changes?
I don't know that I do. Well, it's interesting. I think that when I look at my practice, every 2 or 3 years, it's fundamentally different. The technology improves. There's a lot of reading. On the spot. I think, fortunately, I've learned how to learn, and so I think that's an aspect of it. I make sure that I kind of keep up with the latest. I go to an annual meeting for genetics and participate in a number of discussion groups in genetics to make sure that I'm kind of keeping up with things. It's a lot, but every day, no 2 days are the same. I don't see the same types of families, on any 2 days. Every day is a learning experience. Having a genetic counselor to work with means that I have to kind of know stuff and keep up to date on it so that I'm not telling her nonsense. So I think that it's part of genetics is kind of continuous education, both for myself and for my colleagues and for the families we care for.
How else have you both seen technology impact the way you treat patients?
There's a very wide-ranging answer I can give to that, because obviously there's technology with regards to new medications and new treatments, genetic therapies and immunotherapies, but then you get into more, mechanical, advances. Just having the ability to do a virtual visit with either patients or do virtual consultations with other experts around the country. You can see their faces, they can share their screens with you, that kind of collaboration has just increased since the advent of the internet. With regards to, imaging, for example, your specialty here at SDMI, the machines are just doing amazing things. The MRIs are 1,000 times better than they used to be. PET CTs and other functional nuclear medicine imaging has, just advanced, greatly in the last 20 years. That's allowing us to really better treat both our children and young adults with cancer who, need evaluated in special ways that start to define how we treat these patients and how we stage these patients. Better imaging to evaluate how patients with sickle cell might have damage to their brain from their sickle cell disease or damage to their joints from their sickle cell disease. So, all of those advances are making an impact.
Yeah, a radiologist can provide so many clues for our genetic diagnoses. So the hidden ones, the ones that we can't see, so ultrasound identifying malformations in the kidney, a chest x-ray identifying 11 ribs instead of 12 is a major clue, for us with regard to kind of patterns of diagnosis in kids with developmental delay. Identification of skeletal dysplasias. A really good pediatric radiologist can bring our game up and really help us figure out the exact right genetic test to do for a family. So I think that all technologies rise, but I think that I'm biased. I think that the genetic technology really, our ability to kind of find these answers, even all cancers genetic at the level of the cells, and are able to identify the pathways that they can use pharmacologic agents to kind of attack that cancer. Those are kind of genetics is kind of at the forefront of those advances. I think.
I do not disagree. Yes, yeah, and that goes into our ability to do genetic testing is now increasing at a tremendous rate as well. And you can speak to having whole exome sequencing done for every child born in Nevada would be a goal.
Well, I think for critically ill newborns, I think that is a goal. About 30 kids have got critically ill newborns. Have conditions that rapid whole genome sequencing would be able to identify the answer within 5 to 7 days, and that makes a huge difference with regard to the medical management, what you're able to tell the parents, what you're able to tell about the survivability of the condition, other things, along those lines.
Let's break that down to kind of a layman's terms explanation. Is that a blood test? Is that what is that kind of testing? What does that look like as a parent who's getting ready to bring their child in to have all this testing done? How much poking and prodding are we doing?
Well, so, from a genetic standpoint, there are about 20,000 genes or instructions that are needed to make a person. And it's a little surprising that, in 2025 and, 25 years after the end of the Human Genome Project, that we only have names for conditions associated with 6,000 or 7,000 of those genes. So, 13 or 14,000 of those genes, we know that they're important, that they do something in the body, but we don't have a named human condition associated with that. Every day we discover another named human condition associated with one of those genes. So of those named, genetic, conditions that we know about, we're able to do sequencing of the specific gene, and that's usually a blood test. We're able to sequence the expressed region of about 1% of the genome, which is all of the genetics, but it's where all the action's at. The expressed portion of the genome is where the action's at. And so that's called whole exome sequencing. And then we sequence all 20,000 genes or instructions, including all the intervening sequences and repetitive DNA, and that's called whole genome sequencing. We do some of that testing on newborn screening from a heel stick. Blood test is usually the way that we do that, and we like to do it in a trio. So we like to test the child and the mom and the dad and make a comparison. But one thing that COVID taught us was that you could get that DNA from a cheek swab. So often if there is a known genetic diagnosis in the family, we're sending the family to the delivery room and saying, after the baby's born, swab the cheek, put it in the box, send it off to the laboratory, and we'll tell you whether this baby's affected or not affected with the condition in your family. So the testing has become kind of technically much easier than it was in the past.
I know we had kind of talked a little bit about some specific examples of patients that you've had some success with here in Vegas, and I know you have probably an endless amount of stories. Can you give me some of those specific examples, or maybe touch on one of your favorite patients or one of your most interesting diagnoses in your careers?
It's interesting. I've only been here for 6 months and been seeing patients for about 3, and I've already had 2 career high, families in the orthopedic, realm. And so I'll tell you about one. So it was a family that were carrying a fetus that was identified as having a very small chest and very short limbs, and they felt that this was probably a lethal skeletal dysplasia, so it was a lethal dwarfing condition, and they were advised that way during their prenatal management. And so the baby was born, and indeed did look like they had a skeletal dysplasia, and they had to breathe for the baby, and started the diagnostic odyssey. So we have a fantastic pediatric orthopod at Cure for the Kids, David Stewart. And Dr. Stewart was rounding in the hospital and said, wow, we've got a geneticist now, and maybe, kind of talk about that. So genetic testing was completed, and they found a genetic change in a gene called HSPG2. And that doesn't mean anything to anybody. For that condition, there were two possibilities. One was that this was a perinatal lethal condition where no matter what you did, the child was going to die. And the parents are deciding whether to keep the child on a ventilator or not at this point, or a milder condition where they would actually kind of survive and have a skeletal dysplasia. So they would have short limbs and short stature, but they would kind of make their way into adulthood and would not necessarily die in the newborn period. So those are kind of two vastly different things. So I had this great opportunity to go look at the x-rays with Dr. Stewart. And we're looking at them and we're kind of saying, okay, I see, the vertebral bodies are small. We call that platyspondyle, and there's kind of an appearance to the ends of the bones. And so we were kind of discussing that, and we were able to, with the genetic test and the radiographic features, establish that it was the milder version of the diagnosis. And we were able to get that information back to the family. One of the first cases that I had at Cure for the Kids, and right out of the bat, it was, using the new technology, using collaboration, which I think is another reason that I love being at this organization, and using radiology, to kind of find the answer. And you needed all three of those things in order to get the right answer. One of those things wouldn't have done it, and I couldn't have done it by myself. I needed Dr. Stewart. I needed radiology to be able to kind of help this family.
So talk to me a little bit more, and we're going to get back to your favorite patient, so don't think I'm letting you off the hook here. But talk to me more about those collaborations and what are, obviously radiology, obviously the different specialties within your own practice, but what other specialties are you collaborating with regularly, and why are those relationships so important to the care of the patients?
So for genetics, I think that we collaborate with all the pediatric subspecialties because, their rare diseases are our rare diseases, and so we're often are helping them find that explanation or answer. But I would say that the two specialists that we collaborate the most with are pediatric cardiology, so structural congenital heart disease, diseases of the aorta or the big blood vessel that comes off of the heart, cardiomyopathy, so a heart muscle that's not functioning very well, all of those detected by radiology, and problems in the conduction system in the heart. We call those channelopathies that can be inherited in families. And so we collaborate very closely with cardiology. In fact, we even have a term, cardiogenetics, for that collaboration. And so I work very closely with the genetic counselor at Children's Heart Center of Nevada. Similarly, neurology. So they see individuals and families with intellectual disability or autism, but also with intractable seizures and also with neuropathy conditions, problems of the nerves, and primary problems of the muscles like muscular dystrophy. And so we're very intimately involved in that diagnostic odyssey to kind of bring the answers home to those families. And I could tell similar stories about pretty much any other pediatric specialty, pediatric endocrinology, pediatric gastroenterology, but I think those two are probably the chief ones that we interact with on almost a daily basis.
How about you, Dr. Lasky? What are you seeing as far as collaboration, and how does that really impact the outcome of your patients?
I do have lots and lots of stories. I mean, I can say, to tie back into genetics, for example, we have a family with a rare storage disorder called Niemann-Pick type C, and there are, up until recently there had been no FDA-approved medications for that condition, and more recently there have been some more up and coming. But very early on in their diagnostic odyssey and then their treatment odyssey, there was a study medication that was developed. It's still in research right now. It's not FDA approved yet, and this family initially had 4 boys, and unfortunately the oldest one passed away from their disease, but they have 3 others who are now receiving this treatment. The difficulty of the treatment is it needs to be given with spinal taps every 2 weeks, and so these boys, one of them's now 9 years old, who's been getting spinal taps every 2 weeks for the last 5 years, and so they come to clinic, and again, I'm not a geneticist, but I do have the ability to do spinal taps, and so I help them out by giving them that medication. Prior to us being able to give it at Cure for the Kids, they had to travel to Los Angeles every 2 weeks to get the treatments there, and then we were able to get that medication and that study open at Cure for the Kids, and we've been able to provide that for their 3 boys now, again, for the last 5 years. And the beauty of that medication is that it really works, and we're seeing now, even though the older one is quite severely affected by the disease, the younger 2 are much, much less affected, and so we know we're delaying their disease progression. It doesn't stop it, but it allows them to, again, have very productive little kid lives and do things, and they love going to baseball games. And so that's a rewarding thing on the genetic side for me every 2 weeks. And of course, like he said, I collaborate with Dr. Nunes, with Dr. Longo, who's been with our clinic as well, and that's just been a great experience for me having moved here. And then I guess I would say the other side, I'll do 2 more. So the first one is, I have a young woman now who's 19, who's a survivor of childhood leukemia, and she was diagnosed when she was 15 years old. And so we took care of her at that time, and had the most common form of ALL, and did really quite well with therapy. She the other day, and we see her still once a year for follow-up, but she emailed me the other day and said, I just got into nursing school, but I need some vaccines. Can you help me get those? And I was like, well, absolutely. So even though she's done with her cancer therapy, she still needs a couple little help with medical related things, and we of course still follow her and would love to see her succeed in a nursing career, and she's very smart, and so people talk about the long-term effects of our cancer therapies, and those certainly do exist, but we really are doing our best nowadays to mitigate those factors and allow these kids to go on and lead very healthy, happy lives, and she's going to be able to have children and start a family if she wants to, and obviously achieve her dream of being a nurse. So that's obviously a rewarding thing. And then finally, to kind of get back to collaboration between both genetics, hematology, and frankly also the pharmaceutical industry, we have a new FDA-approved gene therapy for a disease called hemophilia B, or factor IX deficiency. This is a severe bleeding disorder that, again, starts from birth, and it's generally only in males because it's X-linked, and it can cause these children to have spontaneous bleeds into their joints, into their knees, ankles, elbows, and they can get terrible arthritis because of those chronic bleeding symptoms. And the treatment up until recently has been IV replacement of that factor. And so these individuals had to sometimes start their own IVs twice a week or even every other day to give them this medicine just to help protect their joints so they could lead relatively normal lives. And in the last couple of years, they've actually developed a gene therapy cure, or not cure per se, but it definitely helps ameliorate all of those symptoms and allows them to be free of those IV factor replacements. And we successfully gave our first one of those in mid last year to a 44-year-old with hemophilia B, and he is now not needed IV factor for the last year and has maintained normal levels of this factor IX gene that he genetically was not able to produce until we gave it back to him with gene therapy. And again, that involved lots of collaboration, both with our hematologists, with geneticists, with again a drug company that makes this very specialized gene therapy, and we were able to offer this to that patient, and his life is now completely changed.
I've never had a non-genetics boss who knew what Niemann pick type C was, let alone B or A. So, I think it's one of the fun things about being at this organization. And, I think that the collaboration between genetics and hematology and oncology at Cure for the Kids is really this blossoming, wonderful thing. Dr. Lasky now talks about trios as well, and we identify children with cancer genetic diagnoses that a parent's at risk for, and are sending them over to the genetic counselor at Comprehensive Cancer Center of Nevada, and that genetic counselor is identifying parents with cancer genetic diagnoses that could benefit from seeing one of the providers at Cure for the Kids for the pediatric risk for their children. And so kind of just seeing you incorporate this trio idea into the broader Cure for the Kids lexicon is, it just makes me feel like I'm in the right place at the right time.
And I think this is just a really great reminder to the audience that there are some very highly specialized physicians in Las Vegas, and we're very lucky in this area to have access to these kinds of, to physicians like yourselves and those that you collaborate with. What would you tell patients that are watching this that think, hey, I think there may be something with my kiddo that is not quite right? How do they get to you?
Talk to your pediatrician. And so the pediatrician's collecting a tremendous amount of information about your child. They're plotting a growth curve, which is a vital sign in pediatrics that tells us a lot of information. They're collecting information about development, the skills that your child is acquiring. So talk to your pediatrician first. And if your pediatrician is identifying something that could benefit from a specialty evaluation, the pediatrician will make that referral. We sometimes see families where they don't have a good pediatrician or family practice doctor or primary care provider, and those are the most vulnerable people in our population. But it all starts with a really good primary care provider.
How do you guys manage the emotional impact of seeing very sick children day in and day out?
We have a very robust set of child life specialists who are able to help the children and their siblings deal with complicated rare diseases. We have social workers that help parents navigate the financial toxicities of our therapies and of our diagnoses. It affects their jobs, it affects their ability to pay rent or own a car. So we're able to hopefully try to mitigate some of those stresses on the family. And then on the physician and provider side, especially the nurses who are really the frontline workers in caring for these patients, ill patients or patients that aren't doing well really weigh upon them, and of course they weigh upon us as well. And we simply just need to concentrate on the bright spots that do happen and the successes that we do have. And when there are patient deaths that happen that's affecting the clinic, we actually do bring in a grief counselor as needed, to allow an outlet for any of our staff to be able to talk to those individuals. And obviously if other therapy is needed, we would support them in getting that. But I think our company, Cure for the Kids, is now a clinic of 170 people and growing. And we, even though we're getting bigger, we really still try to keep a really collaborative atmosphere within the clinic. And so I think we can feed off each other's successes, and this goes from people who are in eligibility and billing, who help families get the treatment they need. It goes to the nurses who are taking direct care of the families they need. It comes from the doctors who are directing the treatment. So it's really a top-down approach and a whole family approach to caring for these kids. And so I think that even when there's sad parts that happen, I think just having that community around us really helps to, make us get through the day. And like I said, is just really focus on the bright spots and successes that really are the bulk of what happens during our day.
Yeah, I think we're all pediatricians, so we tend to be kind of nice people, in general, from the provider standpoint. But I think Cure for the Kids has done an excellent job of recruiting at every level, from the medical assistant on up through the CEO. Recruiting at every level people that have personalities and traits that work well together. And so, I'll say that there's not a provider in our clinic that I feel like if I'm having a bad day that I can't go talk to who will actually stop and look me in the eyes and will have a conversation with me, as opposed to kind of saying, oh, that's too bad, I'm really busy, see you later, Mark. And I think that I hope that they feel the same about me, that they could kind of come to me in the same way. So I think it genuinely, because everybody's focused on the mission, that it's a genuinely fantastic group, of folks to work with.
What do you guys think is the future for Cure for the Kids?
I gotta take that. Well,
You're the boss.
The future is that we're going to grow, and we're going to continue to provide additional services as we see the need in the community, and that may include adding additional service lines in different departments. But obviously, our focus is also to maintain excellent quality of care in the pediatric hematology, oncology realm, the genetics realm, rheumatology, orthopedics. And then we, look to partner with any other organizations that are going to come into this community to help make access to care better for the families. And that includes a new children's hospital that may exist in 5 years. That includes, new collaborations with imaging facilities, who are going to hire, awesome new pediatric providers for our patients, and we're going to continue, growing those collaborations again to make access to care as best as possible in Las Vegas and Southern Nevada and all of Nevada. Frankly, I think it would be great for patients, not to have to travel out of state for certain types of radiation therapy or certain types of scans that we can't do sedation with here in town. It'd be great if we didn't need to send patients out of town for bone marrow transplantation that we don't offer here yet. And I can list other things as well. So again, I think our goal is to, and it's not necessarily Cure for the Kids that's going to provide those services, but we want to collaborate with the organizations that are going to help make that happen.
So I have one final question for you both. If you could give patients one piece of advice, what would you tell them?
The sun will rise tomorrow. So we have an interesting phenomena that happens in genetics sometimes with this diagnostic odyssey, and that is that families that have been looking for an answer and have been in this world of gray for 6 or 7 years, all of a sudden we give them an answer, and you would think that that was the best news solution, and all of a sudden it's this big loss. You go from this world of gray to black and white, and it's a grieving process for these families that are experiencing that, and we identify that for them, and say, this is what you're going to feel. I know you don't believe me, but you're going to kind of feel this, and sure enough, that happens, and I think it's helpful for families to know that they're not alone and that the sun will rise the next day.
And I think I was going to say my simple sentence would be, get enough sleep.
That's easier said than done.
Well, and I think there's a lot that goes behind that, because I think, first of all, if you're addicted to your work and you don't balance and integrate the rest of your life, you're not going to get enough sleep. If you're stressed about something, you're not going to get enough sleep. And so I think having mechanisms in place to, cope with all of those things, and getting enough sleep is absolutely known to probably be one of the most key determinants of having a healthy brain as you age, and having a healthy body as you age. And I obviously am aging myself, so I'm becoming keenly aware of such things. So, but yeah, I think that's what I would say, is get enough sleep.
Awesome. Thank you both so much for your time today.
You're welcome. It's fantastic.
Thank you.